Hello everyone and welcome back. Session 3 of the toxic effects of metals. As we step into our final session, let's polish things up because after all, even in toxicology, it is important to finish with a shine. Welcome to the grand finale of our metal saga. Don't worry, no headbanging is required. It's not a rock concert, but it does involve some heavy metals. We have saved the best for last. Our final session on metals. Think of it as a desert course. A little heavy, maybe toxic in large amounts, but definitely worth tasting. Here, let's have a quick recap of session 1. We looked into what is a metal, metal as toxicants, movement in the environment, routes of exposure and absorption, distribution in the body, metal transporters and binding proteins, excretion of metals. Metals are naturally occurring elements with unique and physical chemical properties, but may act as toxicants when present in excess. They move through the environment via air, water, and soil, eventually reaching humans through various routes of exposure such as ingestion, inhalation, or skin contact. Once absorbed, metals can undergo distribution in the body, accumulating in specific tissues and organs. Their transport and storage are regulated by metal transporters and binding proteins, which influence toxicity and detoxification. Finally, the body eliminates metals through excretion pathways like urine, feces, sweat, and bile, helping maintain metal balance and reduce the toxic effects. Now, let us look into the concise recap of session 2. We started with biomarkers of metal exposure, chemical mechanisms of metal toxicology, molecular responsible to metal exposure, factors impacting metal toxicity, therapeutic use and toxicity of metals. Here we discussed how the metals can impact human health in diverse ways and understanding the effects in essential. Biomarkers of metal exposure serve as early indicators of absorption and potential health risks. The chemical mechanisms of metal toxicology involve redox reaction, binding to critical biomolecules, and interference with cellular pathways. These interactions trigger molecular responses, including activation of stress pathways, gene expression changes, and epigenetic modifications. The extent of toxicity depends on various factors such as dose, duration, route of exposure, nutritional status, and individual susceptibility. While certain metals have significant therapeutic applications, such as in chemotherapy and medical devices, their beneficial uses must always be weighed against the potential toxic effects.
The highlights for this session are major toxic metals, the toxicokinetics, toxicity, carcinogenicity, and treatment, essential metals with potential for toxicity, toxicokinetic, essentiality, deficiency, and toxicity, metals related to medical therapy, toxicokinetic, toxicity, and treatment, minor toxic metals, toxicity, and treatment.
We will now look into the first topic, that is the major toxic metals. The major toxic metals like arsenic, beryllium, cadmium, chromium, lead, mercury, and nickel represent some of the most significant environmental and occupational hazards of our time. They are not only persistent in nature but also bioactive in ways that disrupt vital cellular processes, accumulate in tissues, and leave long lasting imprints on human health. Arsenic, infamously linked with contaminated groundwater, scars the skin and silently raises the risk of cancer. Beryllium, valued in high technology industries, betrays the lungs with insidious granulomatous disease. Cadmium, hidden in batteries, fertilizers, and tobacco, cripples kidneys and bones over decades of silent accumulation. Chromium, while essential in its trivalent form, becomes a potent carcinogen in its hexavalent state, corroding the respiratory system. Lead, the ancient metal of pipes and pigments, robs generation of children of their full neurological potential with no safe threshold known. Mercury, in its original methylated form, travels through oceans and food chains to impart the very core of human cognition and development. And finally, nickel, a common industrial element, reveals its darker side as both a powerful allergen and a cause of occupational cancers. Together, these metals illustrate how progress and pollution can intertwine, challenging us to safeguard both ecosystem and vulnerable population, especially children, workers, and future generations, from their enduring toxic legacy.
In this table, we will see some of the major toxic metals, starting with arsenic, beryllium, cadmium, chromium. The inorganic arsenate, organic forms like MMA, DMA, seafood arsenobentane, which are usually non-toxic, are some of the forms we find. The absorption in GI is rapid. The inhalation is also a relevant route which also has a capacity to cross the placenta. Distribution is usually in the liver, kidney, skin. It binds to the sulfhydryl groups. The hepatic methylation through the AS3MT through MMA, the capacity varies with folate or SNE status. Excretion is mostly within 2 to 3 days through the urine route, and for chronic exposure, the traces are found in hairs and nails. It inhibits pyruvate dehydrogenase and other thiol enzymes. Oxidative stress, genotoxicity, endocrine and vascular effects can also be seen. In the clinical observations, you can find the GI goes through the stress, hypotension, neuropathy, and through clinical chronic exposures, you can find skin hyper or hypopigmentation, keratosis, neuropathy, anemia, cardiovascular diseases, and risk of diabetes. It can also be considered as a carcinogen, which leads to skin, bladder, lung cancers, and evidences for liver and kidney can also be seen. The presence of urine arsenic speciation is up to 24 hours or spot with creatinine. This acts as a biomarker. It is usually best for recent exposure, which excludes the identification of seafood arsenobentane. For chronic exposure, as told earlier, it usually found in hairs and nails, which reflects the past or the extent of chronic exposure. It does not give a decision for acute decisions. The treatment is by removing the source and providing supportive care. Chelation by dimercaprol for severe acute inorganic arsenic. The DMSA or DMPS for moderate optimization of folate status. The major exposure sources are by contaminated ground water, by tube wells, smelting, pesticides or wood preservative, rice, uptake from paddy soils, certain traditional medicines. The geogenic release from arsenic-rich sediments, mining or smelting are the global cycling processes, and they are usually transported in water, redox controls, or found in speciation, that is conversion from arsenite to arsenate. The plant uptake is usually due in the rice, aquatic toxicity into invertebrates and fish, bioaccumulation is limited versus the finding of methyl mercury, but ecosystem impacts are substantial. The sensitive subpopulations included are fetus or pregnant people, children, folate deficient or malnourished population, or people with renal or hepatic disease. Next is beryllium. The absorption is usually through inhalation route, which is found in lung deposition. The absorption in GI is very low, but long pulmonary retention can be seen. The acute pneumonitis, chronic beryllium disease, or granulomas can be the reasons for toxicity. It is also carcinogen and leads to lung cancer. The biomarkers of exposures are BELPT, pulmonary function tests. The treatment can be given by removing the exposure or corticosteroids for CBD. The major exposure sources are aerospace, electronics, ceramics, and recycling. The industrial dust, low food chain transfer, phytotoxic at high soil levels leads to global cycling. The sensitive subpopulations are workers with LA, DP beta 1 glue 69, asthmatics, and smokers. Cadmium. The GI absorption is very low, but with iron deficiency, it increases and it usually binds with metamethionine and accumulates in kidney or liver. The half-life is found to be in decades. The toxicity of target organs can be seen are in renal tubular damage, bone demineralization, and pulmonary edema, which is found in acute toxicity. It can be carcinogen for lungs and others are possible. The biomarkers can be found through urine in cadmium plus beta 2, M, NAG, and blood cadmium for recent exposures. There is no effective treatment for chelation, but supportive care can cure it. Major exposure sources are smelting, nickel cadmium batteries, pigments, fertilizers, and smoking. Long range atmospheric transport accumulates in soils or rice. Bioaccumulation in bivalves is found for the global cycling. The sensitive subpopulations include smokers, CKD, iron deficient people, or postmenopausal women. Chromium. It is absorbed via anion channels, reduced intracellularly to chromium 3 through DNA adducts or ROS. The respiratory irritation, nasal perforation, and dermatitis are some of the major observed toxicity signs. The lung or nasal cancers can also be caused due to chromium. The biomarkers are through presence of urine chromium for recent exposures. The major treatment could be by removing the exposure of chromium or there is no proven chelation for this. The major exposure sources are by electroplating, leather tanning, stainless steel welding. Global cycling can be seen by the presence of chromium 6 in mobile or toxic phases and chromium 3 in precipitates. It is phytotoxic in the aquatic systems. The sensitive subpopulations include welders, platers, asthmatics, and people with skin disorders. Coming up with the next metal, which is lead, the GI absorption is greater in children than in adults. It is distributed to soft tissue, bone reservoir. The half-life is in bone, it is in decades. The neurotoxicity in children and anemia, nephropathy, and hypertension both are the toxicity impacts. Inorganic lead leads to group 2A of carcinogen, which is probable. The biomarkers of exposure are blood lead level, the BLS or ZPP in chronic concentrations, treatment through DMSA, calcium, sodium, EDTA, and BAL nutrition support. Major exposure sources are batteries, paint, pipe, dust, pottery, cosmetics. Global cycling and ecotoxicology through legal contamination from petrol persists in soil or dust, avian poisoning from shot. The sensitive subpopulations are children, pregnant people, and iron deficient people. Next comes mercury. Forms mercuric vapor and leads to CNS. The methyl mercury in GI tract it is absorbed for 95%, inorganic in kidneys. Methyl mercury has the ability to cross the placenta and blood-brain barrier. It is basically excreted through urine and found in traces of hair. The methyl mercury toxicity leads to ataxia, paresthesias through impacting on the CNS, inorganic It impacts on the kidneys. Mercury, it leads to tremors, gingivitis, and erphism. It leads to group 2B form of cancers in inorganic and group 3 inorganic. It is basically found in hair and blood through biomarker exposure and in urine through inorganic presence of mercury. DMSC or DMPS avoids BAL in organic mercury. Major exposure sources are fish or seafood, artisanal, gold mining, and coal. The global atmospheric transport through aquatic leads to methylation and biomagnification. The sensitive subpopulations are fetus, children, fish-eating communities, and minors. Lastly, nickel. It has poor absorption in GI and through inhalation and dermal key. It is excreted basically through urine. It forms dermatitis or eczema, rhinitis, and GI absent. Might lead to group 1 lung or nasal cancers through nickel sulfide oxide. Biomarkers are through urinary nickel or patch test. Treatment is basically by avoiding or tropical steroid support. Major source exposures are stainless steel, plating, batteries, jewelry and coins, mining, smelting, aquatic toxicity, bioavailability of nickel, phytotoxic in soils are the global cycling and ecotoxicology impacts. Sensitive subpopulations are nickel sensitive individuals, welders, and asthmatics. Let's look into the essential metals with potential for toxicity. Essential metals are like quirky superheroes in the body, absolutely vital, yet a little dramatic when they overdo their roles. Iron, the hero that carries oxygen in your blood like a delivery ball on steroids. But overload him, he turns into a villain, rusting your organs with oxidative stress. Zinc, the multitasker, juggling enzymes, immunity, and wound healing. Miss him, and you're prone to infections. Invite him too much, and he'll upset copper and cause trouble in the neighborhood. Copper, the shiny coin of metabolism, sparking energy production. But if copper parties too hard, like in Wilson's disease, it trashes the liver and brain with toxic rays. Manganese, the handyman of enzymes, quietly fixing antioxidant deficiencies. Yet, too much inhaled at work, and suddenly he thinks he's a neurologist, causing Parkinson like tremors. Cobalt, the gem that makes vitamin B12 glow. Without it, anemia knocks. But let cobalt run wild and it irritates the heart and thyroid like a rock star on a tour. Selenium, the antioxidant bodyguard, keeping free radical in check. But overdose on supplement and it'll flip, causing garlic breath, brittle nails, and hair loss like a diva melted. Molybdenum, the quiet gear turning enzyme in detox. Deficiency is rare, but too much makes it stir up goose like mischief in the joints. Some of the essential metals are presented in this table: cobalt, copper, iron, magnesium, and manganese. Cobalt, it is absorbed through GI, bound to the albumin or transcobalamin, excreted through urine. The part of vitamin B12 which helps in RBC formation, nerve health. Deficiency leads to megaloblastic anemia or neuropathy. Excess leads to cardiomyopathy, thyroid dysfunction, polycythemia, dermatitis, and asthma through inhalation route. Treatment for deficiency is by B12 supplements and toxicity, removing exposure and providing supportive care. For copper, it is absorbed in intestine, bound to ceruloplasmin. It is stored in liver and biliary excretion. It is basically needed for enzymes for cytochrome oxidase and lysyl oxidase (SOD). Deficiency leads to anemia, neutropenia, bone defects, and hypopigmentation. The toxicity in for acute GI upset and liver injury. In chronic, it leads to Wilson's disease, cirrhosis, neurologic issues. Treatment in case of deficiency through oral provision of copper and for severe toxicity, penicillamine, trientine, and zinc therapy. Iron, it is absorbed in duodenum and stored in ferritin or hemosiderin. There is no active excretion found. It is essential for hemoglobin, myoglobin, cytochromes. Deficiency leads to iron deficiency anemia and fatigue, pica. Acute toxicity leads to GI bleeding, shock, and chronic toxicity leads to hemochromatosis, cirrhosis, diabetes, cardiomyopathy. Deficiency treatment is oral or through IV support of iron. For toxicity, it is deferoxamine and phlebotomy. For magnesium, it is absorbed in intestine, stored in bone and muscle, and excreted through renal route. Essential for cofactor in greater than 300 enzymes. Deficiency leads to tetany, seizures, arrhythmias, hypocalcemia. The toxicity is excess, usually renal failure or through supplements, leads to hypotension, arrhythmia, and coma. Treatment is by provision of IV or through oral magnesium for deficiency and for toxicity, IV calcium and dialysis if severe. Manganese, usually through GI absorption, bound to transferrin, biliary excretion, essentiality, cofactor MnSOD arginase. Deficiency is found rare, but it leads to poor growth, bone defects, and metabolic issues. The toxicity through chronic inhalation leads to manganism, that is Parkinson-like tremors, psychiatric changes. Treatment for deficiency is by diet correction, and treatment for toxicity is removal of the exposure and providing supportive care. We shall continue with the essential metals, starting with molybdenum. It is well absorbed and excreted through urine. The cofactors xanthine, oxidase, and sulfite are essential. Deficiency is rare, but it leads to neurodelay, seizures, and lens dislocation. In case of excess toxicity, gout-like symptoms, infertility, and growth retardation can be seen. The treatment for deficiency is by providing supplements, and treatment for toxicity is by removing the exposure and symptomatic reactions. Selenium, absorbed in GI, incorporated into selenoprotein, and excreted in urine, feces, or breath. Essential cofactor glutathione peroxidase, thioredoxin reductase. Deficiency leads to Kishan by cardio, Kishan Beck for bone, and liver low immunity. Toxicity in excess causes cyanosis, that is garlic breath, brittle hair or nails, rash, fatigue, or neuro issues. Treatment for deficiency is by providing supplements, and toxicity is by stopping the exposure and providing the supportive care. Chromium, poor GI absorption, bound to transferrin and urinary excretion. Enhances insulin action by glucose tolerance. Deficiency is rare but leads to impairment of glucose tolerance and neuropathy. Neurotoxicity, generally it is low toxic. High dose leads to upsetting of GI tract and renal or hepatic damage. Deficiency for treatment, providing supplement and treatment toxicity is for giving supportive care. Zinc, absorbed in the intestine, bound to albumin, stored in the bones or muscle, and excreted through feces. Cofactor is greater than 300 enzymes. Deficiency leads to growth retardation, poor immunity, dermatitis, hypogonadism, poor wound healing. Toxicity in excess leads to GI upset, copper deficiency, anemia, and immune suppression. Treatment for deficiency is by providing oral zinc, and treatment for toxicity is by stopping exposure, managing copper loss. Let's look into the next class of metals, that is, metals related to medical therapy. Certain metals though often regarded for their toxic potential, have found an important place in modern medicine as therapeutic agents. Aluminium, bismuth, gallium, gold, lithium, and platinum are notable examples, used in treatments ranging from gastrointestinal disorder and rheumatoid arthritis to psychiatric illness and cancer chemotherapy. Their therapeutic value arises from unique chemical properties such as the ability to bind proteins, mimic essential ions, or interfere with cellular pathways. However, these same properties also make them potentially toxic with narrow margins between beneficial and harmful doses. Understanding that toxicokinetics, mechanisms of toxicity, and management of adverse effects is crucial for safe and effective clinical use. These metals, though toxic in nature, have carved an important niche in medicine, from lithium in psychiatry to platinum in cancer therapy. The toxicokinetic highlight how easily therapeutic metals can accumulate in organs while their narrow safety margins demand careful monitoring. Treatments usually involve discontinuation, supportive care, hydration, and chelation whenever possible.
These are the metals which are useful in medical therapy like aluminium, bismuth, gallium, gold, lithium, and platinum. Let's see the toxicokinetics, toxicity, and treatments for the toxicity of these metals. The toxicokinetics for aluminium involves it has a poor GI absorption which is less than 1%, but it accumulates in bones, brain, and liver. The excretory pathway is usually renal. The toxicity includes neurotoxicity and dialysis dementia and confusion, osteomalacia and anemia. Treatment for this toxicity is to stop the exposure of aluminium, provide deferoxamine chelation and supportive care. For bismuth, it has minimal GI absorption, but it accumulates in kidneys, liver, brain, and is excreted through renal route. The toxicity effects which can be seen are upset of the GI tract, there is discoloration of the gums, encephalopathy can be observed, and even in severe cases can lead to renal damage. The treatment is by discontinuing bismuth, providing supportive therapy, chelation by means of BAL or DMSA in severe cases. Next is gallium. The toxicokinetics is usually through IV absorption. It binds the transferrin, accumulates in bones or soft tissues, and excreted out through renal pathway. The toxicity includes nephrotoxicity, anemia, leukopenia, hypocalcemia, and nausea. Treatment is by giving extensive hydration, stopping the therapy, providing supportive care which does not include any antidotes. Next is gold. It has a poor GI absorption, but it is stored in kidneys, skin, bone marrow, and it is excreted slowly through renal or by biliary pathway. Toxicity usually leads to dermatitis, stomatitis, nephrotic syndrome, bone marrow suppression. Treatment is by providing supportive care, chelation by means of penicillamine or dimicropiol, and by stopping the drugs. Lithium. It is well absorbed when given orally, and it has the ability to distribute into the total body through water. It follows the renal pathway for elimination, and it has a narrow therapeutic index. Toxicity leads to GI upset, tremors, nephrogenic diabetes, insipidus, hypothyroidism, seizure, and coma. The treatment should be discontinued for lithium. IV saline hydration should be provided, and for severe cases, hemodialysis should be taken up. Platinum. The IV absorption is through cisplatin, carboplatin, and oxaliplatin. It binds with DNA or proteins and is excreted out through renal excretion. Toxicity is through nephrotoxicity, ototoxicity, neurotoxicity, and usually leads to symptoms like nausea or vomiting and myelosuppression. Treatment can be given by IV hydration, diuretics, amifostin for protection, and supportive care.
While major toxic metals like lead, mercury, and arsenic attract much attention, another group of so-called minor toxic metals include antimony, silver, tin, uranium, and vanadium, among others, also pose significant health and environmental concerns. These metals are less frequently encountered, yet their industrial, medical, and environmental presence can still lead to harmful exposures. Many of them lack essential biological functions and even in small amounts may disrupt enzyme activity, impair organ systems, or accumulate in tissues. Understanding the toxicokinetics, mechanisms of toxicity, and health risks is essential for assessing their impact on human health and ecological systems, especially as industrial use and environmental contamination continue to rise. So now let's look into the final category of toxic metals, that is the minor toxic metals. Let us now look into the last class of toxic metals, that is the minor toxic metals. Starting with antimony, it is similar to arsenic, creates GI tract irritation, vomiting, cardiac erythemesis, liver damage, pneumoconiosis, that is through chronic inhalation. Treatment is by removing the exposure, providing supportive care and chelators through dimercaprol and DMSA. Barium leads to hypokalemia, muscle weakness, cardiac arrhythmiasis, respiratory paralysis. Treatment is by oral sulfate salts, magnesium or sodium sulfate to precipitate barium sulfoxide, barium sulfate, potassium replacement and providing supportive care. Caesar competes with potassium, upsets the GI, muscle weakness, cardiac arrhythmiasis, radioactive isotopes leads to radiation sickness. These are the toxicity factors. Treatment by Prussian blue for radioactive cesium and potassium therapy provided the supportive measures. Fluorine or fluoride. The toxicity leads to GI irritation, hypocalcemia, hypomagnesemia, alzheimer's, skeletal fluorosis through chronic exposure, calcium gluconate through IV or topical, gastric lavage with milk or lime water, provision of supportive care, palladium. The toxicity leads to allergic dermatitis, eye or respiratory irritation, nephrotoxic, which is rare or most occupational. Treatment is by removing the exposure, providing supportive treatment, and providing the corticosteroids for any kind of allergy. Silver, the argyria, which is irreversible blue-gray skin discoloration, eye or liver, kidney damage at high levels. Treatment, it is, does not have any effect of any antidote. You have to discontinue the exposure. Chelation can be done by penicillamine. It may provide certain relief. Tellurium, the toxicity leads to garlic-like breath or odor, upsetting of the gastrointestinal tract, headache, metallic taste in tongue, and neuropathy. Treatment is usually by providing supportive care, the activated charcoal, and removal of the exposure. Thallium, severe GI pain, alopecia, neuropathy, encephalopathy, and renal and liver damage. Treatment by Prussian blue, which enhances the excretion through activated charcoal, providing potassium supplementations, and in case it is severe, you have to give the hemodialysis. Tin, generally low toxicity, Inorganic tin, when enters into the GI, it gives irritation and headache. Organotin leads to neurotoxicity or immune suppression. Treatment is by removing the exposure, providing supportive therapy, chelation by dimercaprol, and organotin poisoning. Titanium, the low toxicity may cause lung irritation through dust and granulomas, possible immune effects. No specific treatment has been given. Symptomatic and supportive care is required for the treatment. Uranium, chemical nephrotoxicity, that is tubular necrosis, or radioactive isotopes, radiation injury through cancer risk. Treatment, sodium bicarbonate, it alkalizes urine to reduce renal deposition, chelation by DTPA, and provision of supportive care. Vanadium, respiratory irritation, green tongue, cough, GI upset, neurobehavioral changes seen during chronic exposure are some of the toxicity effects. Treatment is by providing supportive care, removing from exposure, chelation through EDTA or BAL, which is reported in some cases. The metals remain a unique class of toxicants because their toxicity is determined not only by dose but also by chemical form, oxidation state, and binding properties. Essential metals like iron, copper, zinc, manganese, and selenium are critical to normal physiology but can produce toxicity when deficient or in excess. Toxic metals like lead, mercury, cadmium, arsenic have no beneficial biological role and are associated with major public health hazards. Toxicity involves interaction with proteins, nucleic acid, and membranes, often through sulfhydryl binding, ion mimicry, and oxidative stress generation. Movement of metals through the environment, workplace, and food chain contributes significantly to human exposure. The biological distribution and storage in bone, liver, kidney, and brain explains both acute and chronic health effects. Chelation therapy provides the primary medical treatment, though its efficiency depends on metal type, timing, and tissue distribution. In conclusion, metals exemplify the principle that the same agent can be both vital and harmful, and the toxicology requires an understanding of chemistry, biology, and environmental science. Before ending this chapter on the toxicity of metals, let's go through the quick summary what we have learned in all these three sessions. Let's look into the summary of these chapters, starting with the definition and diversity. In these chapters, we looked into the occurrence of metals which were naturally like elements with unique chemical and physical properties. We also saw their toxicological significance, which arises from widespread use in industry, medicine, and the environment. Next, the essential versus the toxic metals. Some of the essential metals like iron, zinc, copper, selenium, manganese are required for enzymes, metabolism, and physiological functions, while the toxic metals like lead, mercury, cadmium, arsenic have no biological role but they cause significant health hazards. The determinants of metal toxicity, the various oxidation state, solubility, and ability of metals to bind with biomolecules. We have also looked into the various routes of exposures, which included inhalation, ingestion, and dermal contact. The toxicokinetics, metals are absorbed and distributed to target tissues. Some examples are liver, kidney, bone, and central nervous system. Many of them have long biological half-lives, which causes the bioaccumulation and chronic effects. The mechanisms of toxicity, some examples include binding to sulfhydryl group in proteins for enzyme inhibition, the ion mimicry, where the metals replaced essential ions. Example is lead for calcium and generation of reactive oxygen species, that is ROS, which led to oxidative stress and DNA or protein damage. The various clinical effects. In acute, we saw the GI irritation, neurological dysfunction, and renal injury. For chronic exposures, the developmental neurotoxicity, nephrotoxicity, hepatotoxicity, various bone disorders, and carcinogenesis. The therapeutics and preventive through chelation therapy by EDTA, BAL, DMSA, and use of penicillamine for enhanced excretion or by limiting exposure via workplace safety, environmental regulation, and dietary monitoring. Concluding the chapter, which includes that metals are double edged agents, essential at trace level but toxic in excess. Their toxicology highlights the interplay of chemistry, biology, environment, and medicine. And finally, we come to the conclusion on metals. Metals constitute a broad and diverse group of chemical elements that play essential roles in both biological systems and toxicology. Their unique chemical and physical properties, determined largely by their electronic structure and position in the periodic table, govern how they interact with biological molecules and the environment. The toxicological behavior of metals is complex and is influenced by speciation, that is the oxidation state, ionic form, and complexion, which determines their solubility, transport, and reactivity. The routes of exposure through inhalation, ingestion, and dermal, which significantly affects the absorption and toxicity. Distribution within the body, including storage in target organs such as liver, kidney, and bone. Interaction with biomolecules such as enzymes, proteins, and nucleic acids, where metals can act either as essential cofactors or toxic inhibitors. Many metals are essential micronutrients like iron, zinc, copper, manganese, selenium, which are required for enzymatic functions, oxygen transport, and cellular metabolism. However, deficiency or excess leads to pathological outcomes. Others, such as lead, mercury, cadmium, and arsenic, are non essential and highly toxic, producing multi system effects including neurotoxicity, nephrotoxicity, hepatotoxicity, and carcinogenesis. The reactivity of metals often involves generation of reactive oxygen species, that is ROS, leading to oxidative stress and cellular damage. Binding to sulfhydryl groups of protein, altering enzymatic functions, mimicry of essential ions like cadmium replacing zinc, lead replacing calcium, disrupting normal physiology from therapeutic perspective. Treatment of metal toxicity includes chelating agents like EDTA, BAL, DMSA, penicillamine that bind toxic metals to enhance excretion, although such therapy must be balanced with risk of mobilizing metals into sensitive tissues. Overall, metals are double-edged, essential for life at physiological levels, yet potentially devastating in excess or inappropriate exposure. Their toxicology must be understood in the context of their chemical behavior, environmental movement, and biological interactions. So, everyone, we have finally reached the end of our journey through the metallic maze. From iron and zinc, our body's loyal friends, to lead, mercury, and arsenic, the notorious villains. We have seen how metals can either keep life ticking or throw a serious wrench into our biology. If these three sessions have taught us anything, It's this: metals are like relatives at a family function. Some are essential, some are toxic, and few just refuse to leave your system no matter what you do. On a serious note, I hope you'll remember not just the science, but the balance. Dose, exposure, and form matter the most. The same shiny element that builds bridges and batteries can also break neurons and kidneys if mishandled. So, as Casseret and Dose remind us, respect the chemistry, protect the environment, and never underestimate the tiny ions that shape your life. Thank you for your attention, curiosity, and laughter through all these 3 sessions. May your lives be enriched with just the right amount of iron and zinc and zero mercury in your tuna. Goodbye. Stay safe and may your only exposure to heavy metals be through good music playlists. Taking your leave now. This is Kanchan Mangale. Thank you all.